All right, we are live on Facebook and I pass it over to Amy.
Thanks, Alyssa. Hello and welcome to the Hirschberg Foundation for Pancreatic Cancer Research webinar, What Happens in the Operating Room, Pancreatic Cancer Patients Should Know. My name is Amy Reese and I'm the Patient and Family Support Coordinator for the Foundation. First, I'd like to acknowledge and thank all of our wonderful sponsors who help make these presentations possible. Once the webinar ends, please stick around for survivor chat, where we'll stop recording and give everyone the space to share stories, information, and ask each other questions. Now it's my pleasure to introduce Dr. Jonathan King, Assistant Professor in the Division of Surgical Oncology at UCLA. He is a surgeon within the Hirschberg Center for Pancreatic Diseases at UCLA and has presented at past symposiums and was an honorary medical co-chair of the 2018 LA Cancer Challenge. He has expertise in robotic-assisted minimally invasive pancreas surgery and performed UCLA's first minimally invasive pancreatic duodenectomy, also known as the Whipple procedure. Dr. King is an enthusiastic surgical educator and is developing the UCLA residency training curriculum for robotic-assisted surgery. Dr. King, welcome and thank you so much for joining us today.
Thank you, Amy. And I really want to thank the Hirschberg Foundation, in particular, Aggie Hirschberg, our fearless leader who has been so generous in supporting me, my clinical and research interests, and for the help that she and the foundation and everybody involved with it provide to patients. It is a wonderful resource to have behind us in treating people for this disease that we have such great support and support in doing this, because it really does take a village. So I was very excited to have the opportunity to lead this discussion. I think it's something that, as a surgeon, seeing people in the operating room, one of the great challenges for me is to try to translate to my patients, what is going to be happening, what does this look like, and how do I prepare? And so I think this is a very forward-thinking topic, and one that I would love to hopefully be able to shed some light on, so people can be a little better prepared, because I think that goes a long way in terms of making it a positive experience. As far as conflicts of interest, I have none. And with that, a little bit about me. Here's a picture of me with a few less gray hairs, and but otherwise looking pretty similar, I guess. I was born and raised on the East Coast. I'm a transplant to the West Coast. Bethesda, Maryland was where I called home. And I went to my state medical school, graduated in 2006 from University of Maryland. And I came to Los Angeles in 2006 after medical school for my general surgery training. Was here through 2013. I worked in a lab in a large part in the Aggie Hirschberg Pancreatic Cancer Research Laboratory. And that was my indoctrination into all things pancreatic cancer. I did a complex surgical oncology fellowship at the University of Pittsburgh in 2013 to 2015. And that is where I actually kind of honed my skill set and where I brought the robotic experience kind of into my armamentarium. Excuse me. And then I joined the faculty, came back to UCLA in 2015, where I've been since then. And with my clinical focuses being this minimally invasive approaches to pancreatic surgery, most notably with robotic assistance, which we'll talk about. And then I also work in disseminated intraperitoneal malignancies. So I don't want to spend much time on this because there's a lot of information out there, but just to set the stage for kind of where we're going to be talking. Pancreatic cancer, we all know is a feared disease. It's one that, as a medical community, we're still making great strides in trying to catch up, if you will, to some of the improved cancer outcomes that we see in other solid malignancies like breast cancer and colon cancer. And thankfully, we are making those strides. But some of the challenges that we still face, we'll talk about today. We're going to talk about treatments for pancreas cancer, and then, really, the most of the talk and the thrust of things is what your pancreatic cancer surgery will look like, and what do we do to prepare you for that, and what happens. And then we'll talk a little bit about recovery from surgery, as well as kind of what follows. So the background of pancreas cancer is that it is unfortunately getting more common, and we're seeing more diagnoses. It's not entirely understood why, but it probably has something to do with people living longer in general. But we do know about some risk factors. Smoking is the #1 preventable risk factor, or modifiable risk factor, I should say. There is some association with the incidence of pancreas cancer and carrying excess weight, being overweight, pancreatitis or inflammation of the pancreas, and then a complicated, difficult to define relationship between diabetes and pancreas cancer. We know that diabetes doesn't cause pancreas cancer, but it may be associated with it. But we have trouble exactly nailing down what the details of that association are. We know that about 10% of people will have a family history. So there's definitely a genetic predisposition. But again, it's somewhere where we're learning more almost by the day, but we don't have all the answers there. And we certainly know that there are certain types of precancerous cysts that we can see on imaging and that predispose people to developing cancers. One of the signs and symptoms, well, the most common, particularly for tumors of the head of the pancreas, is jaundice. Along with that can be itching and dark urine. Digestive problems, kind of as an umbrella, kind of term, can certainly be an early indicator, but they're oftentimes non-specific. And that goes to one of the problems we have is just, how do we know when somebody has, a pancreas tumor? And oftentimes it's not clear. Abdominal pain certainly can sometimes be a clue. And how do we diagnose it? Well, most oftentimes a CT scan will give us an idea that something's there, whether there's a cyst or a lump or a mass. But really the diagnosis is made these days mostly with endoscopy and biopsies that are performed. And as far as treatments, well, once we have a diagnosis, well, then we go to treatment, and surgery is at the forefront of treatment still. This is the #1 treatment we have. So whenever possible, surgery is generally recommended. Chemotherapy is a close second. And again, most of the time, chemotherapy ends up being recommended at some point in the treatment process. Radiation we use selectively. And an important consideration is palliative treatments. And people often don't fully realize that palliative means symptom management. And so this is not end of life care. No, this is throughout treatment. We have palliative means to alleviate things like jaundice, for instance, and other problems that may arise. Many people have problems with digestion because of abnormalities of how the enzymes from the pancreas are being secreted. And so there are medications that people sometimes need that help to digest foods. And that's all considered palliative treatment, and something that is very important for management. So I mentioned, briefly that this is a challenging disease for patients, for clinicians, for families to deal with. What are some of these challenges? Well, probably the #1 from a clinician and patient perspective is metastasis or spread of the tumor outside of the pancreas. Many times this is the case with pancreatic tumors, that it has this ability to spread, often without us knowing. And so that's probably challenge #1, and can oftentimes limit our ability to offer treatments such as surgery. I've shown this picture here, that tumor that invades critical structures, I said. Most often this is blood vessels. And so here you can get a sense of, these blood vessels here are all very intimately related to the pancreas itself. The head of the pancreas is traveling, actually through and around these blood vessels. And so it can be a challenge for surgery to be able to separate the tumor from these vessels sometimes. For patients, intensive treatments, so chemotherapy, surgery, these are intensive treatments, and you require a lot of support to get through them, and so that's something that we have to consider. And then symptom management. This gets back to palliative treatments. So how do we manage these symptoms so that then you're able to get your surgery or to receive chemotherapy, and so these are all important considerations. Just briefly, so surgery obviously removes the tumor and surrounding tissues. We actually aim to remove some normal tissue around the tumor itself, so that we're getting what we call clear margins. Basically when the pathologist gets that piece of tissue, they want to see that the tumor is clear from the edges, because if it's not, that implies that there could be tumor left behind. So we always look for having negative margins, we say, which just means that all those edges are clear of tumor. Surgery, when we can perform it, is the single most effective therapy. We get the most efficacy in terms of survival, in terms of symptom management, in terms of clearing the body of disease with surgery. But unfortunately, not everyone is a candidate. So that's obviously something that has to be evaluated on a case-by-case basis. The surgery for pancreas tumors tends to be complex in that there is a potential for significant recovery time, and unfortunately some potential also for delays in that recovery. And we'll talk a little bit about that. And the biggest Achilles heel of surgery, if you will, is that it does not treat tumor outside of the pancreas. And so when somebody has had spread of their tumor outside of the pancreas, unfortunately, surgery, generally speaking, becomes something that is not an option. But there are other options, and so we get to chemotherapy. So in this, with chemotherapy, these medications that are intended to slow the growth, to kill the tumor cells, these medications circulate through the entire body. And that's important because we know that these tumors have the ability to spread on the cellular level throughout the body. These days, chemotherapy is recommended for nearly all patients. They're the exception rather than the rule in terms of people who don't need chemotherapy. And so I tell my patients that generally speaking, it's wise to plan to be getting some form of chemotherapy at some point during their treatment. Multi-drug regimens are now the standard of care because they have the best efficacy. They're the ones that work for the most part. Side effects, unfortunately, are common, but are generally manageable. And so that's something that the medical oncologists have gotten very good at in terms of being able to get people through their treatments in a way that is something that you can manage. Radiation, as I said, is used selectively. This is where high energy beams directed by the radiation oncologists are used to treat a localized tumor. So similar to surgery, where this is a local treatment and something that we generally offer when it's a question of locally controlling the tumor. But on the good side of things, it's generally very well tolerated. So radiation is something that generally has few side effects. And then I mentioned palliative treatments are treating symptoms, and that's regardless of stage or regardless of other treatment goals. All right, so now we're going to kind of start zeroing in on the surgical aspects because I'm a surgeon. That's what I know, and because that's what we're here to talk about. So most common question I get probably in clinic, when we're trying to get ready for a pancreas surgery, what can I do to prepare? So there's medical considerations, there's nutrition and activity and exercise. And then managing anxiety and quite honestly fear. This is a scary process, and we understand that as clinicians, even if we don't talk about it all the time. So starting with medical considerations. So, one of the things about pancreas cancer is it does tend to be a diagnosis that comes along in people later in their lives. And so there oftentimes are other medical issues that we're dealing with at the same time. Diabetes frequently is coexisting with the pancreas cancer, and oftentimes can be made worse with a pancreas cancer, such that many people who were diabetic but well controlled find themselves having difficulty controlling their blood sugars around the time of a new diagnosis of pancreas surgery. So that's something where we get our endocrinology colleagues involved early in terms of if insulin needs to be started, for instance, managing high blood sugars so that we can get those optimized as much as possible before going to the operating room, which is part of the medical optimization. We also obviously need to ask questions about, well, how strong is the heart? Are the lungs up to a big surgery? And so these are questions we pose to our medical colleagues, and there may be testing involved in terms of making sure that everything is good to go before surgery. But I will say that it's a rare instance when people just simply don't have the strength to go to surgery. I also get questions about, well, how old is too old to get a pancreas surgery? There is no age cutoff. We've done Whipple surgeries on 90-year-olds, and that's an important thing to realize. There in the past has been some degree of nihilism in even the medical community about, this person just is too old to be even considering this type of treatment. No, that is very much not the case these days. We have ways to mitigate and deal with all but the most debilitating medical issues, such that really everybody is a candidate for treatment of some sort. So that's an important realization. I made a special note of bile duct stenting. So I mentioned jaundice is a common presenting complaint, initial complaint that people will come to, and that's yellowing of the eyes as a result of blockage of the bile duct. And these tumors oftentimes do that, particularly when they're in the head of the pancreas. When that is the case, we will oftentimes have our gastroenterology colleagues endoscopically place a stent. That means they go in with the camera in through the mouth, down the esophagus, into the stomach, and then they can access the bile duct and place a stent in there to open up that bile duct and allow the bile to flow from the liver into the intestine where it belongs. And that's an important step in getting people ready for surgery oftentimes. There are selected instances when we don't do that stenting, but again, those are the minority rather than the majority. As far as nutrition, we have had numerous great talks in the last several Hirschberg symposia about nutrition in pancreas cancer. And so I don't want to wade too far outside of my area of expertise, but from a surgical standpoint, what I always emphasize to people is that protein and calories are important to be maximizing leading up to a major surgery, and not just pancreas surgery. So this is where things like protein supplements sometimes come in. And there's numerous brands that are out there. You can get most of them just over the counter, and some of them are reduced sugar for people with diabetes or problems with high blood sugars. And generally speaking, some of these protein shakes that are available, will have multiple grams of protein in them, such that if you're getting one or two of those, even when your appetite isn't that good, you can get most of the protein requirements you need for a day. And so that's important going into a surgery where you need those protein calories, because they're really the building blocks. They're what help you heal from the surgery. Vitamin deficiencies are something that can come along, particularly with when the bile duct is blocked, and is a big reason why we oftentimes like to have a stent in place to get the bile flowing before doing the surgery. Pancreatic insufficiency. So one of the jobs of the pancreas is to supply enzymes that help us absorb fats from our diet. And so sometimes when those enzymes are insufficient, we will supplement with oral enzymes that are taken. And so that's, again, something that based on symptoms, your doctor can determine whether or not that's necessary and prescribe them as necessary. Activity and exercise. So I often tell people the stronger you go into your surgery, the stronger you're going to come out on the other end. And so absolutely, walking is the key to being strong, going into that surgery. And so I advise people to begin a regimen of as tolerated exercise as much as is feasible. Because again, if you can be fit going in, that bodes well for your recovery. Managing anxiety and fear. Well, this is a big component of being at peace with this, and this is where the Hirschberg Foundation support groups, talking to people that have had the surgery. Hopefully, things like this forum can help give you knowledge so that you can come into things knowing a little bit better what to expect. And certainly, it's the unknown that is most often the scariest. So having some knowledge of what's coming is oftentimes the best way to manage and mitigate that. All right, so here we are. What happens on surgery day? All right, it's a big day, right? So first of all, actually stepping back a little bit, the day before surgery, we don't typically require bowel preps, like a colonoscopy or something where you have to take medications to, flush your system out. That's typically not required, but we do generally advise, a liquid diet the day before surgery. And then generally speaking, we limit your intake the morning of surgery. Those instructions obviously come from your surgeon and the pre-op instructions that they give. Here at UCLA, we do all these surgeries at the Reagan Hospital, and so that means arrival early in the morning. At the admissions department, and then up to the second floor where we have our perioperative treatment unit, the PTU, a little picture of it here. And basically the first step is that you'll meet your PTU nurse, and you start meeting the OR team, and multiple team members will come in and assess, and the RN will place an IV catheter. They'll take your vital signs. You'll meet the anesthesia team, and they'll begin to discuss with you the plan for anesthesia. And then your surgical team comes by. Obviously, if I or one of our other pancreas surgeons is your surgeon, you will have known us from your clinic appointment, but we all work with a residency team as well. And so we have a chief resident and a junior resident on the team at all times, as well as a nurse practitioner. So these people all come by and you'll meet them, and hence this slide, which I've said, who are all these people and what do they do? Because it does seem like a parade of individuals that come by. And so, as I mentioned, in the preoperative area, you'll have a bedside nurse who interviews you, assesses, and places the IV. They review the documents. You'll be asked multiple times, what procedure are you getting today? It's not because they don't know, it's because they want to make sure that they have the right patient and the right procedure. So all part of their pre-op checklist. Your OR nurse comes by, and she's going to be, or he or she is going to be in the OR with the surgical team, helping them. They also are important in that they will communicate with family during the operation, such that they'll be able to provide updates on, here's where we are in the operation. A surgical technician, you probably actually won't meet this individual, but they're the ones also called scrub techs that assist the surgeons in the OR. They're actually scrubbed into the procedure with us and assist us. Anesthesia. So there's actually two anesthesia groups. There's the analgesia team. This means pain control team. And so they are a special, deserve special consideration. They're the ones that place the epidural catheter. So at UCLA and many institutions, we routinely use what's called an epidural catheter. And this is a very fine tube that goes in through the back into the epidural space. So it's actually not where the spinal cord lives, but one layer above that spinal cord. And this catheter infuses local anesthetic as well as a very low dose of a narcotic, such that we can avoid typically all IV narcotics. And I'll tell you why this is important in just a moment. But needless to say, that's a minor procedure that they do there in the preoperative treatment area. And so this analgesia team, you'll meet, they discuss with you the epidural, and then they are responsible for placing it. And then they round on you afterwards. So during your postoperative recovery, this is one of the teams that comes by on a daily basis, assesses how well the epidural is working, because this epidural stays in for generally 4 to 7 days after the operation. And they help us manage that. And then there's your anesthesiologist. So this is the individual that will, it's actually a team as well, that will be responsible for administering the anesthetic medications during the operation, monitoring you and basically keeping you safe while the surgeons work. They are also responsible for helping with recovery from anesthesia. So in the post-anesthesia recovery area. And then, of course, there's the surgery team. And I mentioned that that consists of myself or one of the other surgeons, as well as a resident team. And that is the same team that will be responsible for your postoperative care on the wards. All right, so I promised you a little bit more about the epidural. Here's what it looks like. So the epidural is actually going into the back around here. It's still fine, you can barely actually see it, but they do typically tape it to the skin with one of these clear adhesive dressings. And then it's connected to a device on the IV pole. And that's what administers the medication on a continuous basis. Again, it's a catheter or tube that goes into the epidural space, which is next to the spinal cord. And what it does is it allows delivery of very low doses of these medications right at the roots of the nerves, so that postoperative pain can be basically nipped in the bud, if you will. It keeps excellent pain control, and it avoids IV narcotics. We know that IV narcotics, which is kind of the traditional route for treating postoperative pain, have a lot of downsides, most notably that they slow the intestines and actually can prolong recovery. So one of the biggest advantages to the epidural catheters is that they help people get out of the hospital faster. There's also dysphoric or delirium that can be associated with narcotics, and so there's actually a lot of reasons that we are very happy to avoid the IV narcotics if we can. So the epidural catheters are fairly routine. There are specific instances when either we can't or we don't recommend them, but these days those are the minority, and most people, we generally do recommend these to our patients. They stay in for about 4 to 7 days generally. And as far as alternatives, on occasion people, again, have a reason not to have one, or they just simply don't want one. And when that's the case, absolutely, we can proceed without it. And we tend to then go back to the traditional approach, which is usually involves IV narcotics, but we have narcotic sparing medications as well that we can oftentimes use. So after the epidural is placed, you talk to all these people, everybody's ready to go. The anesthesiologist will typically give a small dose of a relaxing medication while you're still in the preoperative treatment area. And quite honestly, that's the last thing most people remember. Next thing they remember is waking up in the recovery area. So that's by design to some extent, but is convenient as well, because that takes away a lot of the anxiety associated with this understandably anxiety-provoking event. We transport you to the operating room. And that's where we perform our surgery. And so depending on who your surgeon is, what your tumor is, and where it's located, and what specific operative considerations are in play, we have multiple ways that we perform these pancreatic surgeries. So the traditional approach, which I've outlined in quotes there, because it's how we've typically done these operations, is with an incision. So on the right-hand side, the picture here shows that most of these surgeries we do with a midline incision that's between the breastbone and the umbilicus, or the belly button. And that allows exposure of the pancreas, and we are able to remove the tumor that way. And then there's the minimally invasive approaches, and there's actually two categories here. There's laparoscopic, and there's robotic assisted laparoscopic. I term it robotic assisted laparoscopic because that really is what it is. It is using a robot to assist the surgeon in using tools that are actually similar to the laparoscopic tools. It's not too different from when a pilot flying a jet airplane is, has a computer between the cockpit controls and the control surfaces that steer and guide the plane. That computer is there to basically scale the pilot's movements, make them smooth, take away any tremor, and that's what the robot does for us. And it also gives us greater degrees of freedom, such that we can do things that with the standard laparoscopic instruments we can't do, or is much more difficult. So here's a picture of what it looks like. You see a surgeon sitting at what we call a console. There's a bedside assistant, and there's this machine that holds the instruments and guides them, while the surgeon is the one who's controlling them. Very common question I get is, well, what if the robot makes a decision to do something, cuts the wrong thing? Well, there's no ability for that. The robot doesn't have any autonomy. It is simply a tool that is basically translating our movements. We also have the advantage of a three-dimensional view, and I'll show you a little bit of what that looks like. And so where do we use these different approaches? Well, the most common, there's really only two surgeries that we do for pancreas cancer. One is called the Whipple surgery. That's the big one. That's the one that's the most complicated. And this is where the robot is really helpful for us. And it allows us to do these surgeries in a minimally invasive fashion. So it involves removing the head of the pancreas, which is typically where the tumor is, the duodenum, or the first part of the small intestine, which is kind of cradling the head of the pancreas, and then part of the bile duct, as well as the gallbladder, and then plus or minus part of the stomach. Believe it or not, actually, the functional consequence of removing part of the stomach is essentially nil, such that we see equivalent outcomes whether or not that piece of the stomach is removed. And so it comes down to basically technical considerations and surgeon preference as far as to whether or not that piece is removed. Reconstruction. So the Whipple operation, the reason it's complicated, in addition to involving all these parts that are removed, is that then we have to reconstruct that whole conglomerate of structures. And so here is a schematized view of what that looks like, where we make a new connection between the pancreas, the cut edge of the pancreas, and the intestine, the cut edge of the bile duct in the intestine. And this is your own intestine. These are your own parts that we just reorient and replumb, basically. And then we make a new connection between the stomach and the small intestine. And so that allows all of the digestive juices and bile and everything to go to the intestinal tract where it needs to be, and allows your food to go from the stomach into the intestines, and where digestion will happen and allow you to eat normally. So as I say, for the Whipple operation, this one is done either open, which is the traditional approach, or in my and my partner's hands, we do these primarily actually robotic assisted laparoscopic. And then the other operation we have at our disposal is for tumors of the tail of the pancreas, which are quite a bit less common, then what we call distal pancreatectomy. And this is a operation that removes the tail part of the pancreas, and we typically combine this with removal of the spleen because of the nature of the lymph nodes that we need to retrieve as part of the treatment for these tumors, and so the spleen typically comes along with us. And then there is no need for reconstruction for this one. So typically we are able to remove this part of the pancreas, the spleen, and then there's no need to sew anything back together. In these operations, we do robotic assisted laparoscopic, open, and then also just straight laparoscopic. So because we don't need to sew, we don't need to do this complex reconstruction, we sometimes don't need the robot for this. It's just not necessary. This is what it looks like as we're preparing to do one of these surgeries. We actually use these instruments. They're called trocars. They basically allow us to pass instruments in and out of the body. And you can see the size of the incisions that are associated with these are pretty minimal. And so that's what allows people's recovery to be much quicker in having these smaller incisions. So once you're in the operating room, the anesthesiologist will then give you medications to have you go off to sleep. They place a breathing tube because this is general anesthesia, and so there's a breathing tube for the duration of the operation. They may place another IV, and then our OR nurses will then prep the abdomen, which involves cleaning the skin with a cleanser, and then draping. So all this blue is our surgical drapes, and this establishes our sterile field, we say. So these are, our sterility is maintained with that. These surgeries are long, lasting between 3, sometimes even 8 hours or more, depending on what all we have to do. And our goals are to remove the tumor. We assess the margins, meaning we send that tumor, once we've removed it, to the pathologist, and they give us an initial assessment of whether or not there's any tumor at the edges. And so if there is, we sometimes will take a little bit more. And that's one of the safeguards that minimizes the likelihood of then having additional tumor left behind. So these days it's rare that we end up with tumor left behind. And once the pathologists have called us and said, nope, all the margins are clear, then if we're doing a Whipple operation, we do the reconstruction then. That's where we make all those new connections. And then we close the incisions, and basically you get woken up from surgery, or excuse me, woken up from anesthesia, we call emergence, and go to the recovery area. It's a minority of patients that need to go to the ICU after surgery. We routinely send people to the general nursing ward, and that is where people do their postoperative recovery. So I promised you a quick video. This just to introduce the video is a portion of the operation that is, one of the more critical parts. We're doing a Whipple operation here. So we're removing the head of the pancreas, and what you're going to see is as we're making a tunnel behind the pancreas, right on top of the purple structure that we're working on top of is actually one of the main veins going into the liver. So I'll hit play on this, and you're going to see this is slightly sped up, but we use these robotic instruments. There's actually 4 hands in here. There's the robotic surgeon. There's also the bedside assistant who's also operating some instruments. But the robotic surgeon's the one that's actually working the tissues here. And so you see we're making this little tunnel as we go through, and we emerge on the other side, and then that is a critical step that then will allow us to divide the pancreas and then take the final steps of removing the tumor from the body. And then this is part of the reconstruction. So here we're actually taking that cut out of the edge of the pancreas and joining it to the intestine. So the intestine we see here on the left in this smooth structure here. And you're going to see these instruments in their really dexterous manner are able to sew very small structures. This is actually magnified about 1.5 times. So this person here had a pancreas duct that was only a couple millimeters, and we can sew that very, very precisely with these instruments and still do it with, as I say, small incisions. All right, so what do we expect now? Here we've made it through surgery, and we find ourselves on the nursing ward, and now we're recovering. Well, first of all, we can expect it's going to be about 4 to 7 days of time in the hospital. That's kind of average. The robot does offer a slightly quicker time to discharge on average. But I still actually tell people, even when we're using the robot, 4 to 7 days is a good timeline to plan for. Day one, right off the bat, we have you up, walking, getting out of bed. And that's the most important thing that any individual can do in recovering from a surgery like that, is to be walking from day one. So we get you walking, obviously with help, because there's a lot of hardware. There's IV pole and some tubes and wires. So we got to help for you, but we got to get moving. We generally are able to give you some sips of liquids by mouth. Nothing exciting, just a little bit of water, sometimes a little broth to sip on and wet your whistle. And I say here, tubes and wires. Yeah, lots of tubes and wires. So there's continuous heart monitors and a good deal of hardware on this first day. But one of the things we can look forward to is that with each day of recovery, we tend to remove 1 or 2 tubes or wires, and to the point where you're getting unfettered as you go. By day 2, we're generally able to give broth and jello. By 3 and 4, we routinely place surgical drains. So these are little rubber tubes that go in through, actually, if we're doing a laparoscopic procedure, we repurpose one of those incisions to have a drain go through there. And this drain is our window into the abdomen. This is how we tell if a new connection between the pancreas and the intestine is healing the way it should. If it does, then typically on day 3 or 4, we're removing that drain and getting rid of it. We don't need it anymore. And usually most people are getting a try of solid food by day 3 or 4 as well. And then the days that follow, once we see that you're eating okay and that things are going well in terms of the intestines having recovered from surgery, then we remove the epidural. We transition to pain medications by mouth, and we start preparing for discharge. Home recovery, you'll see, is 6 to 12 weeks. That's a long time, and it does take this long. Most of that recovery, though, is the lion's share of it is done early, and you do experience kind of a tail end of your recovery where it does seem to plateau for a little while. And that's why I put this 6 to 12 week number, because if we're honest with ourselves, that's the amount of time it's going to take before you start feeling more or less yourself. You'll be doing the things you need to do in a day and getting around. You're certainly not in bed for all this time, but it does take us that long to get to that full 100%. We generally have a post-operative clinic visit about 2 weeks after discharge. For some people who end up going home with their surgical drain, this is when their surgical drain can be removed. And then after that, as I mentioned before, most people are going to go on to get chemotherapy. That means visiting with the oncologist and getting established care with them so that chemotherapy can be given. So, some kind of bulleted points. All right, well, what to expect after surgery? Well, that 6 to 12 weeks, the things that kind of are commonly reported are fatigue, meaning just feeling tired through the day, needing to take a nap when perhaps that wasn't your routine before. Not having the energy to go out and go shopping at the store, for instance, but again, still getting up, walking around, being ambulatory, but not having the energy to do some of those more strenuous things perhaps. And poor appetite. What does this mean? Well, I generally recommend to people that they change their diet immediately after surgery in such a way, change how they eat, not so much their diet, but how they eat, and such that you're eating smaller, more frequent meals. One of the very common things we experience or see, and it has nothing to do with taking whether or not you took a piece of the stomach, is that people just feel full after eating relatively small amounts. And so that is the reason why it's important to take kind of frequent small meals. We tell people to become a grazer. And to be always picking at something, making sure that you're getting all those nutrients that you need in the day, but not trying to pile it in 3 square meals, because that just tends not to work as well for people. Eventually, after the 6 to 12 weeks, people return, a vast majority of people return to their normal eating habits, such that if 3 square meals a day is how you like to live, I would expect you to get back to that. And then I mentioned that, the surgical drain is there for at least 3 days after surgery. And there are some instances when we need to keep it for a little bit longer to allow that new connection to heal, particularly the one between the pancreas and the intestine. So I've been very careful to add emphasis on the words that I want to emphasize here. So what not to expect after surgery. All right, so complications, delays to recovery, unfortunately are part of some people's recovery from pancreas surgery. We've come a long way as surgeons, as medical community in making this surgery safe, but it doesn't change the fact that there are sometimes delays to recovery and something that we have to manage. One of the more common complications, if you will, or delays to recovery can be a pancreatic fistula. So where we connect the pancreas back to the intestine is a delicate connection, and it's something that has a propensity to leak just by nature of the tissues and how they heal. And when this occurs, most often it is managed without any further intervention other than leaving the surgical drain in for a little longer to allow it to heal. But in about 10%, or actually a little bit less of the time, there can be a persistent fistula or drainage that can require even additional treatments. But 10%, that means 90% don't have this problem. So we still, that's why I say what not to expect after surgery. So there are things that we look out for, but we by no means expect them. Another common problem that, and when I say common, we're talking about 10% of people will have problems with their stomach not emptying well. We don't actually understand exactly why this happens, but in some people, the stomach doesn't do its normal job. It doesn't recover in the timeline that we would expect it to. And that can delay the start of oral intake, food, being able to eat food by mouth. And so when that does happen, it usually is something that is managed while you're still in the hospital. There are instances where it persists for a time. And in those more severe cases, sometimes people need IV nutrition. We're talking low single-digit percentages in this. And so that is not something that we see very often, but it does sometimes happen. The more common types of issues or delays to recovery that we sometimes see are infections, so urinary infections, and sometimes a skin infection actually is very unusual when we use a minimally invasive approach, so small incisions. There can be infections inside the abdomen, pneumonias, these types of things sometimes happen, but are quite a bit less common than some of the other things. Blood clots, again, sometimes happen. We generally give a low-dose blood thinner to prevent this. And certainly for my patients, people go home with a low-dose blood thinner for the first 30 days. Bleeding, possible anytime we do surgery. And then medical complications, these are things like heart attacks, strokes are rare, much less than 1%. And so not something that we expect. Well, we've talked a lot about the robot, about open. Well, how do we decide who gets what? Well, some of it has to do with the surgeon. And so, if your surgeon is comfortable with these techniques, then they may offer them. As I say, pretty routinely for my patients, we find that we are able to do a robotic assisted approach in a vast majority of cases. There are very few times when we won't offer that. And usually these are instances only of where there's a problem with the tumor connecting to vascular structures, to blood vessels. As far as a community of surgeons, we have some data, but it's not perfect in terms of comparing the open and the minimally invasive approach. This is one of the better studies comparing some of those results. And what we find is that certainly blood loss, this stands for estimated blood loss, or EBL, is less when we do a minimally invasive approach, which means, generally speaking, less risk of a blood transfusion. The completeness of resection, meaning how often do we have positive margins, actually favors the minimally invasive approach. But it wasn't something that was a big enough difference to out of hand say, well, we should do all these open, minimally invasive. Lymph nodes. So we tend to get a few more lymph nodes when we use a minimally invasive approach. And then length of stay consistently, meaning this is the amount of time you're in the hospital after surgery, consistently is less when we do a minimally invasive approach. This was some work actually done by one of our own, Dr. Gerges, when he was at Pittsburgh, and looking at the approach, meaning robotic versus open, and some of the more important oncologic outcomes. And one of the things we talk about is, did people get chemotherapy after their surgery? And one of the things that influences whether or not people got their chemotherapy is, did they have complications? Certainly if there are complications, that can delay chemotherapy or even prevent people from getting chemotherapy. And so what we saw was that the complications were slightly less when, particularly severe complications, when using the robot. And that meant that people were able to get their chemotherapy. And so that actually translated to about a 2.5 times higher likelihood of getting their chemotherapy after a robotic approach. The problem with this data is that it's not a head-to-head comparison. So in the medical community, we always want to have a head-to-head comparison. We simply do not have that data. So this is the best we have right now. And certainly, in terms of kind of putting it in a nutshell, we know that these minimally invasive approaches are at least as safe as the open approaches. As far as specifically what outcomes are improved, we can say that the shorter stay, less blood loss tend to be very consistently shown. And as far as the overall oncologic benefit, how does it help us treat these tumors overall? It's a bit of an unknown, but there is some signal to indicate that it may actually do a little bit better, but we need more data. And this was from that same study where they saw that there was a slightly better, potentially a slightly better survival in people who had minimally invasive surgery. Again, probably related to the fact that more people got chemotherapy when they had a robotic surgery rather than the surgery itself. All right, so what about post-treatment follow-up? So you've had your surgery, you've now had your chemotherapy. What's next? Well, we surveil. So there's then a period of actively looking for recurrence of the tumor. And that means clinical follow-up, meaning coming in to see your oncologist, your surgeon, assess symptoms, find out, hey, how are you doing? And then blood testing. Most people will have a tumor marker, we call it, or a CA19-9. And that is useful for monitoring whether or not there's been recurrence. So that blood test is important. And then imaging, we get CTs or MRIs typically, where we actually visually look to see if there's any evidence of tumor recurrence. And this happens every 3 months for the first 2 years typically. And then we space it out. Certainly the longer you go without a recurrence after your surgery and chemotherapy, the less likely that recurrence becomes. And so we have the luxury of being able to spread some of the surveillance out to every 6 to 12 months until we get to 5 years. And then generally it's every year that people get screened. But it all depends on the clinical situation. So certainly this plan is altered as needed and as determined by clinical situation. All right, so what are our summary and conclusions? So Pancreas cancer, it's a complicated problem. It requires a team approach, and we've got a great team. So I have all the confidence in all of our practitioners, our nursing staff, everybody. And it's not just me. I hear this all the time. So that always makes me feel good to hear, how great our team is, because certainly I feel that way. Surgery is still the most effective treatment for pancreas cancer. Our biggest, hurdle there is just when can we do it? Certainly when there are indications when just we don't have the possibility to do a surgery. Well, that's when chemotherapy comes in, and it is typically recommended for nearly all people, either before or after surgery, or as a standalone when surgery isn't possible. Radiation we use selectively. And then, I think it's important to understand that risks associated with surgery, with chemotherapy, with all these treatments are nearly always able to be managed and minimized in such a way that we can give these treatments safely and effectively, and within the goals of individual patients. That's a huge piece of it. Is what do you want? What do you want from your treatment? What are your goals? And so never let that, never lose sight of that. Surgery day is anxiety provoking. I get it. But you know what? This is manageable as well. And my personal, thought is that education is key, knowing what to expect. So hopefully this is a small piece of helping in that respect. And then recovery from surgery. It's a major undertaking, but doable. So we do it all the time. People do it all the time. And what seems insurmountable oftentimes is surmountable, I should say. And then finally, new technologies may speed your recovery and improve some outcomes. That's some information that we're still waiting to get a little bit more solid of a recommendation from, but certainly there seems to be indicators that some of these robotic approaches really do help patients. And to close, you can do this, and we are here to help. So that's also something I want to emphasize. All right, so I guess from here we can open it up. Amy, I guess I'll let you kind of moderate, and if we want to look at some things from the chat for a bit, then I'm happy to answer that, or live.
Thank you so much, Dr. King. That was an excellent presentation. We have a lot of comments. You're welcome to go in and read them, but I would like to get to the questions. So I'll keep my comments to a minimum. We have George is asking about the difference between myeloma pancreas and pancreas cancer.
A little hard. So, multiple myeloma, myelomas in general tend to be a non-surgical disease. So I will be honest that that's not something that I'm very well versed in terms of myeloma. So, certainly there are instances when these tumors occur in a localized fashion, but we generally rely on the hematology oncologists to tell us as surgeons, this is something that we think should be addressed surgically. And so I have to defer on that one. I'm sorry. Where I can offer better insights is the actual pancreas tumors. These are solid malignancies that fall well within the practice of a surgeon such as myself. So sorry about that.
Another question, is it able to liquid biopsy by blood tests in the future? What do we know?
Yeah, so this is one of my interests that's near and dear to my research heart, and something that the Hirschberg Foundation has helped to basically move forward. That's a very exciting question in lots of malignancies, and in particular pancreas cancer, where one of our big challenges is getting early diagnosis. We really don't have a tool for early diagnosis, unlike breast cancer, where we have mammography, and colon cancer, where there's colonoscopy. So liquid biopsy is, the idea that you can take, blood from a patient and be able to diagnose something like pancreas cancer. We don't have that ability now, but it is something that is investigational in the sense that people in the lab are very much working on that, because it's a very exciting idea.
Great. And lastly, George asks, is it a good idea to remove a patient's gallbladder after treatments?
So It's a routine part of the Whipple surgery. Every Whipple surgery, if there's a gallbladder there, that's part of our resection, what we remove. For if somebody has a tumor in the tail of the pancreas, what we're doing then is typically what's called a distal pancreatectomy. We tend to leave it alone unless there's some problem already. If somebody has stones that are causing symptoms, then yeah, that's a situation where we could potentially be removing the gallbladder concurrently. So for pancreas cancer, like what we're talking about today, adenocarcinomas, we tend to leave the gallbladder for, unless it's part of a Whipple operation. For neuroendocrine tumors, which is a small subset of pancreas tumors, that is a little different. And for those patients, some of the treatments for the neuroendocrine tumor can actually predispose to problems with the gallbladder. So we actually routinely will remove the gallbladder when we're removing a neuroendocrine tumor in many cases. So that does come to pass sometimes, even not part of a Whipple operation then.
Okay. And Maria has asked about the epidural being in place for so many days, but I think you answered that. That's for pain control, correct?
Right. So yeah, that's the beauty of the epidural. The anesthesiologist will use it in the operating room for pain control as well. But the biggest benefit to it is afterwards. And yes, it is there for on the order of about 4 to 7 days. It's very we rely on them heavily, just because they do provide such good pain relief. And so they tend to be worth it, and something that we tend to leave in.
Great. Are any targeted? Oh, Aggie, go ahead.
I have 2 or 3. Many questions were answered as you went. How many hospitals in the USA are doing robotic surgery today?
Robotic surgery in general,
Not for
but yes, for pancreatectomy, it ends up being a much smaller piece of the pie. So this is very much a developing, field. And certainly, 2013 to 15, when I was in Pittsburgh, you could probably count. I wouldn't be surprised. I don't know is the short answer. I wouldn't be surprised if it was less than 25 hospitals or so that were routinely doing robotic assisted pancreas surgery back in 2013 and 2015. Now there's been a proliferation of this, such that now there's many more, but still it's the minority. Less than 10% of complex pancreatic surgery, so Whipple's, pancreatic aduodenectomies, are done with the robot here and now, in this day and age.
Right, and I have one more. We have many patients that have 3, 6, 9, 1 year, 2 years worth of chemotherapy, and they can go into the surgery room. Because the tumor shrank
Sure.
via chemotherapy. Also, we generally hear that even before surgery, there's sometimes a 3-month worth of chemotherapy.
Absolutely. Yeah. So that is a bit of a change, that's come along. The biggest reason for that change is probably that we have more effective chemotherapies. So, certainly when I started training, in the early 2000s, the chemotherapies didn't have a whole lot, even our best medication regimens did not have a whole lot of efficacy. Now with the newer, regimens that the medical oncologists are able to offer and deliver, we can actually expect that there can be clinical response, which is new for us in pancreas cancer. And so that has caused us to kind of change course and in some instances, recommend the chemotherapy up front before surgery. Usually in the instance of a concern about whether the tumor is involving a blood vessel or budding, sitting next to a blood vessel. When that's the case, we fairly routinely will actually flip the script and do the chemotherapy first 3 to 6 months, oftentimes, sometimes even longer. There's lots of reasons that could be a talk in and of itself, but basically that's where we get the best results, is by giving that chemotherapy up front. And then yes, absolutely, we bring them to the operating room. We can do the surgery actually open, robotic. There are really very few things that push us towards the open these days, because we can do the vascular reconstruction and resections, also robotically, and so we're getting more and more facile with this technology, so it allows us to do these more and more.
Oh, that was absolutely wonderful. Amy,
Thank you.
what's our next step?
Well, we have a lot more questions, so
Yeah, I could keep working on through some of these. So yeah, Amy, what else you got for me?
okay. Any targeted trials such as intraperitoneal chemo and injection to tumor by stereotactic approach?
Yeah, so you asked the right person in terms of the intraperitoneal chemo. So that's the kind of other clinical program that I headlight on here at UCLA. For pancreas cancer, I do get these referrals because it's very common for pancreas tumors to spread in the peritoneal cavity, what we call carcinomatosis. But it tends not to be a useful therapy for pancreas cancer. And the reason is that where we find benefit for intraperitoneal chemotherapy, what's called HIPEC, it stands for hyperthermic intraperitoneal chemoperfusion. Where we see benefit for that is what we call low-grade malignancies. So these are things that are typically slow-growing tumors that have a limited ability to spread elsewhere in the body. And unfortunately, pancreas cancer doesn't fit that mold. Pancreas cancer is a bad actor in the sense that it has the ability to travel, really where it wants to in the body. And that means that if we try to treat the belly cavity maximally, we can sometimes see that there is growth of tumor elsewhere that is not being treated by that maximal, treatment to the belly. And so it's a blind spot, if you will. And so that's where we just find that it's not a useful tool. As far as stereotactic injections, that's something that certainly is not standard of care. As far as research protocols, which was the original question, there are none here at UCLA that I know of. Many of these injections, they're actually injecting immune modulators and that types of thing, or tumor vaccines. So I don't know of any of these active in the Los Angeles area, certainly. But clinicaltrials.gov is the clearinghouse where all these open trials that are recruiting are, and certainly anybody can search that. So that would be my first recommendation in terms of looking for something like that.
Thank you. Rick asked a question. What percentage of your patients have chemo before surgery? And have you seen a steady increase in the number of cases which can now be brought to a point where surgery is possible? So
as far as the percentage of patients getting chemo before surgery, we're probably looking at somewhere on the order of about 20 to 30%, I would say. And as far as an increase in the number of cases, absolutely. Most of this has happened not, in kind of the earlier parts of my career. So, when I was still in training, that's where these newer chemo regimens were being, kind of used more routinely. And that absolutely led to an increase in the number of people that we are able to, quote unquote, downstage to the point where, we take a situation that perhaps is not operable, usually because of a local characteristic of the tumor, that it's, affecting a blood vessel. They get chemotherapy and then are able to come to surgery. And so there was definitely a bump up in that, when these regimens, started to become used widely. And yes, we definitely see more of that. This is also incidentally one of the instances when we will apply radiation sometimes before surgery, is to, again, shrink a tumor or treat a tumor in an area where we're concerned about it, abutting a critical structure.
Alyssa, did you want to ask a few questions from Facebook?
There weren't any questions from Facebook.
Got it. Okay.
Yeah, I can
I've
help.
got one from Sammy I'm seeing that is, there's no need for chemo, radiation, and surgery. This is only for the existing traditional therapy. So I guess the question is, are there approaches, not traditional approaches that I've outlined here? And I mean, the short answer is yes. I think where I caution my patients, when they tell me that they want to pursue this as primary treatment, is that there's oftentimes little, if no data, to tell us whether or not it's effective. And here's where, in terms of, guiding me as a clinician on efficacy, there really needs to be some data for me to recommend something that shows that this is likely to be effective. And where that data doesn't exist, I'm not able to recommend that type of treatment. So that's really the biggest barrier to recommending something that would fall under the umbrella term of alternative treatments. Is just what scientific data do we have to guide our use of that? And oftentimes, unfortunately, the answer is little to none. So that obviously influences our recommendation.
Well, we have a lot more questions, and I think we can get them answered. And you can always reach me at amy@pancreatic.org. And for any questions that we weren't able to get to, Dr. King, I may reach out to you for some answers.
Absolutely. Yeah, I welcome the opportunity. And yeah, thank you all for being here and listening in. And I hope you got something out of it, and we can help you in this journey.
And I'd like to say, just give you my gratitude for giving us this more than an hour of your time. I know you were in surgery this morning, so we're just grateful that you carved out this.
Well, thank you. I appreciate the opportunity, and I'm forever grateful to the Hirschberg Foundation and the whole family. So I welcome the opportunity to give back what little I can. So long.
Thank you again, Dr. King, and we will do our best to get answers to anyone whose questions we weren't able to get. So, and those of you that want to stick around for survivor chat, please do.
Okay.
We can be big.